We have selected some topics just to give you some awareness of what it is so that we can actually look at what these things are at your own time and develop your own skills in this area. And one of these topics is that outcome measures in PMR, which is actually a growing topic. You would have seen this discussed, some of the outcome measures are discussed in previous talk, like you have seen some of them in brain injury rehab talk. Glasgow Outcomes Scale, Ranger Los Amigos, and you have also seen in some other talks also in spinal cord injury talk. So this is an extension of those talk, and I'll add few more into it. So what are we going to look at today? Type of measures, why it is important, rehab outcome measures in the context of ICF, types, and I also talk about patient-reported outcome and patient-reported experience measures, which is sort of interest I have. Now, what are the measures you know? Can you tell me some of them? Just in terms of outlining them. So clinical measures, you all know about clinical measures. You check blood pressure, check temperature, you check a lot of other things. And you know what it does, how you use it. It's like a basic MBBS level. Then you have process measures, which actually look at a process, how something happened. I'll explain that in a minute. Then you have outcome measures, what the outcome of something. And then you have something called a balancing measure. And I explain this using some simple thing, like, so you are supposed to be climbing a wall. So you have a wall, you're supposed to climb the wall. What will be the outcome? What is the outcome measure? It's a very simple thing, one function. What is the outcome measure here? What's the outcome measure? Have you climbed the wall? Did you climb the wall? Did you go up to the wall? That's the outcome measure, reaching there. Now what is your process measure? What all things you did to climb the wall? Did you go and do a bit of training? How much time it took to climb the wall? You can develop a lot of things. But what is your balancing measure? What did you lose when you climbed the wall? How many times you have fallen down before reaching there? That could be a balancing measure. Because everything you achieve something, you lose something, or you may not achieve something. So it's very common in clinical practice, because in Western world, this discharging a patient as early as possible is an outcome measure. So there is actually key performance indicators on how many days a patient stay in the ward. But what happens after that? Some of those patients are not completely treated. So they end up in emergency or somewhere within few days. So that's a balancing measure. So achieving something, you're actually not treating something very well, and the patient comes back to the hospital. So when you look at this, you also look at these process measures, outcome measures, balancing measures. If you want to have further discussion on it, please come to the IAPMR 2026. We are going to do a quality improvement workshop during that conference. Now, why do we have to measure? I mean, rehab is, according to me, rehab is a costly activity. It is not very simple. If you actually look at if you really run a good inpatient rehab program, the cost of running that program is very high. I mean, you might think that running an ICU is very costly. Not true. Rehab is very costly business. So we want to actually say that we are doing all these things, we are spending all this money, we are spending all this energy, and we are achieving something. So tracking a change. Also, it's established a common language. When I say something, this patient has improved to some level, you understand what I mean. And you get some feedback about interventions. The problem with a lot of rehab interventions are, we don't have a lot of evidence, unfortunately. Yes, individual patients improve, but you put it collectively to thousands and thousands of people, we don't see that improvement. It is the evidence for a lot of rehab measures is not like our immunology medication evidence. So it gives you some feedback about intervention. It benchmarks one unit to other unit, or benchmark what you do to other units. We have in Australia called Australasian Rehab Outcome Measure. So every rehab unit in Australia need to present their data centrally. And every 6 months we get a report on where we are standing with other rehab centers in the state, other rehab centers in entire Australia. So we know our stroke is actually doing better than other places or same, anything. We get information about everything. So the benchmarking is improved. Payment. In many Western countries, how much money you get depends on what outcome you produce. And I'm recently told some of the private insurance companies in India is also looking at that. This value-based care, bundled care, all those things, where it is the payment depends on how much you actually get. Then research. As you know, you use a lot of outcome measures for research. So these are sort of measures or outcome measures, sort of why we need outcome measures. An ICF model, I know you all need to know about it, or you already know about it. Everything rehab can actually put into this. So it can be put into body function, activity, and participation. And similarly, you can actually put these outcome measures also into these areas. I mean, there are basically two types of clinical outcome measures. Clinician reported, like you all do this and you all report this. And then this is my interest, the patient reported. I mean, ultimately you can think about a lot of things, but ultimately that patient is important. You can say that we have achieved so much, but patient cannot walk, patient cannot participate. To me, it's complete waste. They go somewhere else. So ultimately, their satisfaction is important. So more important is that what they report. Now, all these measures need to be valid. It need to be reliable. It need to be sensitive enough to actually identify the change. Sometimes even most of these measures has got something called minimum change it identifies. Below that, it cannot identify. It has to be generalizable, and it has to be easy to implement. Some of the problem with these outcome measures we use in research is that they are very difficult to implement in clinical practice, because the amount of time required to collect and code those is actually quite time consuming. And other one is it has to be easy to communicate. Now I'll actually direct you to this website. This is PMR Knowledge Now. I like this, and it actually gives you a lot of information, updated, free, produced by APMR. I'll encourage you to look at, gives you a lot of information. Now, how do you select an outcome measure? There are a lot of outcome measures. I'm not going to discuss many of them. I'll just give you some brief line. You have to look at the care setting. Is it inpatient, is it outpatient, is it community setting? Population of interest. What condition are you looking at? Is it, there are general outcome measures, there are specific to certain condition, there are even outcome measures specific to certain symptoms. So you can actually look at, and also you need to look at these what the validity of these outcome measures in the population you are looking at. And also the other thing is that why you want this outcome measure? Are you looking at outcome measures for research? Are you looking at outcome measures for quality of care? Are you looking at outcome measures to report to your board meeting or your executive meeting? Because each one has got its own thing. If you want to be a research, you need to be quite reproducible, rigid. In quality, if it's 90% correct is also fine, because you're actually, in quality, you're looking at a trend. You're not looking at one number alone. You're looking at that number over a period of time. Board meeting, you probably require a very good quality data, because that depends on your survival, especially some of the private hospitals. Yeah, you have to tell them how much money you make. And somebody recently told me that it is every 1 rupee you have to actually make 11 rupee for the hospital. I don't know if it's true or not. The other thing is implementation. How easy to implement these outcome measures. Now, this is basic rehab. Functional independent measures is actually a global outcome measures can be used in many acute rehabilitation settings. Having said that, in a lot of places, this is actually becoming less glorified nowadays, but it's still used in many places. We started using in Vellore many years back. I don't know, Raji, whether we're still using FIM. So it's actually developed in 1987. It's actually an extension of a previous measure called Barthel Index. The problem with Barthel Index was it actually only could show large changes. These actually tell you what's the burden of care. So something like, I'll tell you what it is. It has got 13 motor and 5 cognitive tasks. So an ordinal scale between 1 to 7. So minimum score is 13 and maximum is 126. So basically what it says is that, no, the next one. So these are the domains. So you got motor domains and you got cognitive domains, and these are the numbers. So 1 to 7, 1 is maximum assistance and 7 is complete independence. So if you actually get a score of 100 and above, that basically tell you that you are independent. And your burden of care can be actually determined by the score you get. In a simple thinking, it's a bit Western though. If you get a score 80 and above, you require less than 2 hours of care per day. And if you get about 40, you require 4 hours plus care per day. If you look at these numbers, they are actually, the weightage is quite interesting here, because the 1 and 2 as well as 6 and 7 has a higher weightage compared to other numbers, just to make it even, so that you can actually look at the burden of care. It's a statistical, interesting statistics they use to reduce the ceiling effect we call. You can actually look at the total score. You can actually look at the motor score, adding all the motor one. You can actually look at the cognitive score. You can look at the admission, the FIM at admission, FIM at discharge, and that will actually tell you the FIM gain. So discharge FIM minus admission skin will give you the FIM gain. You can actually look at the FIM efficiency. Total FIM divided by number of the days patient is in the hospital will give you an efficiency. And you can actually use this for burden of care. We actually still use this. A lot of our disability support is based on the FIM numbers. The only problem with FIM is that when a patient is walking, sort of ambulant patient, the FIM gains may not be very significant, because, as you know, a lot of those FIM areas are in the ambulation area. So most of the time, if patient is actually able to walk, they actually score at least more than 5 in most of the motor FIM area. So if you're really doing an ambulatory rehab model, FIM efficiency may not be very good. So we have to actually look at something else for that. So they've got a lot of variations of FIM. They looked at FIM in subacute setting, so alpha and sigma FIM. We have a VFIM for actually pediatric population, and then multiple variations of Lawton, which actually again come from the extension of FIM, which actually used in more ambulatory setting. Then I come back to the ICF model. We have body structure, activity, and participation. So when you have body structure, you have many of those outcome measures, like you in the spinal cord injury talk, George Sack mentioned about ASIA scores, ASIA impairment scale. You all know in spasticity, especially the Botox injecting people, we use modified Ashworth, multiple scores for pain, from very simple to very complex, one called brief pain inventory and all those things. I think a lot of people who do shoulder research use the shoulder pain and disability stuff. Aphasia, the discussion yesterday had, they were talking about Western aphasia battery, Boston naming test. 6-minute walk test, this is something which you need to know in basic rehab thing, looking at aerobic capacity. And upper limb one, you have Figel-Mayer, action arms test, box and block, Purdue. The only problem with all these things are, this is actually quite popular in the research world, especially the stroke, but not many people use this in clinically. Quick dash, Jepson hand function test is again used, but I have not really seen a lot used in a pure clinical setting, but a lot used in research and semi-research settings. Lower limb, River Mead Mobility Index, work balance test is actually something which is used very commonly in clinical scenarios, especially looking at the rehab outcomes. Timed up and go, something which you really need to know. So you basically have to actually have a 3-meter walkway. The patient has to get up from a chair, go up and come back and sit, and the time taken to do that. It's something very easy to do in research, easy to do clinically, something which you really need to know. And 6-minute walk test is, I mentioned again, it's another one. It's a time taken to take a 6-minute walk. Sorry, distance walked in 6 minutes. There are plenty of falls efficiency scales which you could actually look at. Unfortunately, one of the problems in Western world with rehab is number of falls. The moment you actually make people to walk and do things, they're going to fall because their balance is not that perfect. Cognition, I think there was some discussion about few different things. MMSE, unfortunately, MMSE has actually gone into a patented mode, so it's difficult to use. Adam Brooks, it's an interesting one. I think Ashish McAdam is going to talk more about Adam Brooks tomorrow. It is something which actually has translated into many Indian languages from a person who actually worked in Adam Brooks, who actually is from Sri Chitra in Trivandrum. So it's actually translated into many Indian languages. So if you really wanted to look at the cognition, Adam Brooks is something I would suggest. Walking while talking test is used for divided attention, and there are plenty of executive function tests which you can actually look at if you are interested to look at the frontal lobe functions. There are plenty of participation ones. I'm looking at the next aspect. The quality of life measures, goal attainment score, SF36 is probably some of you people know, and there is a shorter version of that used in research quite a bit. There are scales on social integration also. Then if you can actually put this all into a diagnostic specific one, you can have plenty of things for stroke. Barthel, Figel-Mayer, Berg balance, Western aphasia battery, amputee, the 6-minute walk test. There are multiple amputee mobility predictor. I still don't know how useful that sort of validated in Indian scenarios. We use quite a bit to determine what type of processes we should go, because some of our patients has got infinite range of options available. So this is something which you look at things. So you have the predictor score without prosthesis, and then with prosthesis. That will actually tell you whether they are eligible for a high-end prosthesis or not. Then there are plenty of things for arthritis. A lot of you people know about the oswestry. SPADI, I think Renal uses quite a bit for his shoulder one. The SPADI, and there are a few other things which actually can be used in. So that brings to this question about patient reported outcome measures. So most of these outcome measures are clinician reported, Now, some of these outcome measures I discussed, the patient also can report. Instead of you reporting it, you give the paper or something to the patient, and patient takes them. So these are reported by patient and family. There are reports, there are sort of measures available for generic use or specific conditions, similar to what I discussed before. Serially, you collect them at multiple intervals. That actually gives you the trajectory of care. It is actually populated in many Western world, because actually the Western world is looking at the patient-centered care, and so this is an important thing, and a lot of our payments are based on whether we are actually collecting these or not. And actually, it's actually my experience on it is actually improve the engagement of patients in actually decision making, goals, and care. And we have to identify that core set we wanted to actually look at, and then how you can actually use them for the continuum care. It's not one set of measurement. It's how do you measure at sort of at particular interval, and also we tend to measure them even after their discharge. And again, you have general and condition specific. There are a lot of logistics in collecting patient-reported outcome measures. One good thing is that a lot of this electronic health record, if you have one, and I've seen a lot of corporate hospitals in India has probably some of the best electronic healthcare records I have actually seen. And actually, you can incorporate these into the electronic health record and use them. The other thing is that with a lot of people having mobile phones with high-end technology, and it's basically a computer in your hand nowadays, you can actually send this to as a message to the patient's phone, and like many of the airline companies gives you the surveys. And then patient can report it, and you can actually collect the data. So the logistics of collecting these are actually getting easier. So there's a lot more scope in actually using these for research and day-to-day care. We do a lot of work in actually patient-reported experience measure. We actually try to get patient along with us in the journey, try to understand their issues. So we actually send our patients a message with a survey on 3rd day of admission, 7th day of admission, and then every week till they discharge, and they get then after they discharge, 1 week after the discharge, and they can tell us how they feel their care was, and if they have any specific concern, and we can actually use that to immediately sort out their problems, and also use that in longitudinally. So it's actually quite exciting world in this, looking at these outcome measures. You can use it for research, you can use it for clinical measures, you can use it for improving experience, improving interaction, and with electronics moving forward, there is a lot of these can be put into electronics format, and something like a MS form where all the QR codes comes from. If you got the MS account, Microsoft account, MS form is available. It's free, and actually developing a survey in MS form and sending the QR code or link to somebody and actually getting that, and it will automatically provide a report. So there are a lot of avenues in actually doing this. So there are a few references. I've mentioned about PMR knowledge now. The other interesting area, if you actually are interested in outcome measures, is Shirley Ryan Ability Lab website. They have a website on rehab measured data set. Shirley Ryan was a Rehab Institute of Chicago earlier. So I got fantastic website. They do a lot of collaborative work with all over the world in actually looking at the rehab outcome measures. And thank you. If you scan and give me feedback, it would be useful.
Good morning, sir. I am Dr. Sapna from RML Hospital, Delhi. Sir, I wanted to ask, how do we decide which outcome measure is best appropriate for a rehabilitation patient? Like you said, patient reported, but it can vary according to the patient moods. You also said it could be performance based, but a patient might perform better at home, but he might not perform well at a clinical setting. Also, there could be subjective bias between two clinicians, right? So, how do we decide?
In reality, one is the report, the outcome measure you're selecting should actually remove some of those biases. But actually that is not true, because none of our outcome measures are perfect. They are only used for certain population better than certain other situation. Now, so it's complicated, it's not that easy. So you have to actually look at, so I would always suggest somebody, if you're looking at an outcome measure, you look at the most simple ones. And then you look at, in your setup, with the time constraints you have, what is appropriate to use. It might be, I mean, you don't have to use anything very complex. You can use a simple one. And it could usually, even you can have something like a scale, like less, more, those type of sort of options also. That also gives you some better information than what you already have. So it's again, it depends on what you wanted to use and what your experience is. In patient reported measures, yes, that's a concern a lot of people have actually raised. But our experience is that patients actually report pretty well. Because the simple thing is that you go to a restaurant and your experience and your expectation in a restaurant is a particular level. You don't achieve that, you actually complain. But when you go to the hospital, what's your expectation? Get out of the hospital as soon as possible. That is the only expectation. So you actually, in hospital or healthcare world, people are a lot forgiving. So it is not really, they don't actually put that depends on what the real issues are. That's our experience actually doing this for a period of time now. We also thought the same thing, whether they will actually they don't like you, they put something against you. No, not really. We have not seen that at all. We have seen very genuine requests, very genuine experience measure. We even actually put a net promoter score. Whether you will recommend our center to other people. And we will publish that. We are very happy to publish that. And that's an area where if you really wanted a quality healthcare, that's what you actually wanted to look at. So there are a lot of concern people raise, but in real world they are not.
There have been attempts to promote and use ICF itself as an outcome measure. What are your comments on that? They develop even ICF core sets. So what are your comments to use them as an outcome measure? What is the present scenario?
ICF, I don't really know. ICF Excel.
ICF core sets.
Yeah, I've seen that.
Yeah, and they were to be used like just like FIM was used at admission and discharge. They promoted that use that as an outcome measure. There were attempts, and then they developed courses and they gave scores of -2, -1, 0, +1, +2.
So that's a goal attainment. It's similar to goal attainment. Goal attainment. So you basically we have used that quite a bit in. So I think it's very similar to goal attainment, where we actually use in quite a bit in spacity management. You actually develop a goal and you actually define what will be, are they more, are they less? So they have -2, -1, 0, and +1 and +2. And you can actually develop that for any rehab goal. So in most of the inpatient rehab setting, you have actually developed rehab goals when the patient get admitted, and then you actually review that rehab goals until patient get discharged, and then you actually put them into minus thing. And I have seen the goals, ICF goal set, but I don't really know how they actually divide that, sort of define that +1, -2 in that ICF goal set.